Hello viewers, it's Mehak Shaheen, Vision Specialist from Al Ibrahim Eye Hospital and Isra University, Karachi. Today I'm here discussing retinal tears. Retinal tear is a very risky problem as it can lead to blindness. Retinal tears. So, retinal tear, it's basically a break in retina as its innermost layer of our eye. So here I'm discussing about how it's occur, its pathophysiology, risk factors, clinical features, and diagnostic procedures, investigation, and finally we will discuss the management, how to manage retinal tear. Retinal tear, it's basically a different types. It's depend that which pattern it's forming in retina. So if there is an abnormal vitreous adhesion and lattice degeneration, it can lead to retinal tear, and it can also lead to rhegmatogenous RD, which is the break RD, retinal detachment. According to the shapes of tear, we have a U-shaped tear, linear tear, L-shaped tear, operculated tear, giant retinal tear, and dialysis tear. U-shaped tears is like a horseshoe shape and linear pattern forming, so we call it the linear pattern. L-shaped, if the tear is forming, it's L-shaped, and operculated, it's a simple if we just make a hole in a paper and that hole is fully extracted from that paper, it's formed an operculated surface, and this is called the operculated tear. Giant retinal tear, it's a big tear, and I have given in the picture, you can see and understand well. But the dialysis, it's a tear but without any trauma or any procedure. There is just a tear comes, it's come in dialysis. So it's a very impressive shape in which it's clearly defined about complete U-shape, the linear pattern, L-shaped, operculated, and dialysis. Giant retinal tear. It's very clear shown in the picture how the retina detached and forming a tear over here. It's a big giant tear. Pathophysiology. Pathophysiology, it's one of the important factor that how this happen and leads into RD. Basically, in vitreoretinal retraction, there is a posterior margin base during which sometimes the posterior vitreous detached from retina and results in retinal tear formation. Retinal term, we can call it retinal break or retinal hole as well. So it's pathophysiology based on the three important factors which you should remind always when you're seeing the patient of RD. One is there is an abnormal mobility, existence of a partially liquefied vitreous gel. Number two is the tractional forces that are normally present in our vitreous, and sometimes these tractional forces it's behave abnormally and physiologically results in the retinal break. The third one is the presence, sometimes the retinal break allow the passage of liquefied vitreous into the subretinal space of retina. Here the clear picture is for you to easy understand. It's complete eye picture and there is a retinal tears. It started from the retinal tear. There is a break in retina, and why it's called? It's because at the back vitreous fluid is coming behind the retina. The fluid comes and it's totally detached retina from vitreous. So this is a very clear picture to understand that how the abnormally fluids come behind the retina and it's detached from retina results in the retinal tear formation. Risk factors, in rheumatogenius RD, according to ocular and systemic, both are the important features we should know. As regarding eye, we have a journal expects refractive and lenticular and retinal. In journal, there is a blunt trauma penetrating or any surgery. In myopia is a high risk factor for RD, and in lenticular is we have aphakia, pseudophakia, especially complicated surgery, vitreous loss, posterior capsulotomy. And retinal, we have the three more common types, which is the risk factor for RD. One is the lattice degeneration, retinocytosis, retinal necrosis is very common. And other than eye, we have a contralateral retinal detachment, especially which cause in the giant retinal tear. Systemic, we have the three main rare formation syndromes, that is the Stickler syndrome, Marfan syndrome, and Ehlers-Danlos syndrome. When the RD patient comes with the clinic features, the patient having, when we examine the fundus, and if the patient is with acute RD, so there can be a retinal horseshoe tears, and the patient complains of floaters secondary to vitreous debris like a West ring, hemorrhage, or retinal pigment epithelium cells shown in the fundus of that RD patient. Patient complains of flashes of light that in bright light it's very irritating. It seems to be photopsias, and it's because of there is a wet restriction or reduced vision. Patient is complaining blurring of vision as well. And as we know, phototapsias may be due to the depolarization of receptors. When the retina is pulled by the vitreous, so the depolarization of receptors starts and the patient seems the photopsias. Signs are the very important factors as well. The horseshoe tear we form in retina, and the tears usually at the vitreous base near the equator of the eyeball. Giant retinal tears found at 3 or more clock hours of extension, posterior vitreous detachment. Pigmented cells in the vitreous can be seen. Tobacco dust-like and Schaffer sign, and vitreous hemorrhage is the main sign of RD. Pigmentation surrounding tears can be found in the retina. Vitreous traction, localized abnormal vitreoretinal interface, that is in lattice degeneration. Very easy, you can differentiate, you can do the DD between, this is the picture over here, vision with floaters, how the picture seems to be. Floaters are very clearly shown in this picture, and when the patient complains of flashes, what type of picture he has to face with the difficulty. Vision with flashes and vision with floaters are very clear in this picture. So let's come towards the diagnostic procedures. As we know that the patient should be proper diagnosed, so we have a slit lamp biomicroscopy with a 60 to 90 diopter lens, but mostly we are using the 90D as it's giving a very large field of view. A Goldman's 3-mirror lens required to examine for a broader view, and thirdly we have an indirect ophthalmic examination with scleral depression may be required to identify how the retinal breaks formed. So it's very easy by indirect ophthalmic examination, very clear picture of retinal breaks we can see. After diagnostic with the proper tools of ophthalmology, now we come towards the investigation. For investigation, we have an ultrasound. The patient should go for ultrasound that we can see the possible retinal tears, and if there is any detachment or vitreous hemorrhage prevents that, it can easily prevent from direct visualization. So we have to investigate. OCT, which is optical coherence tomography, could be used to evaluate PVD, posterior vitreous detachment. Laser photocoagulation is one of the procedure for the management of retinal tear, as with a minimum of 3 concentric rows of laser required just for this RD patient. Posterior breaks can be managed more easily with a slit lamp or an indirect laser delivery system. Without treatment, observation indicates if the tear is chronic, the tear is demacerated by pigmentation, there is absence of vitreous found in selected asymptomatic patients. So it's not necessary that the patient is diagnosed with RD. First of all, we have to observe the patient, its fundus. Without treatment, that what are the findings? Management is very important and the basic factor. Finally, we have to manage the RD patients. The general treatment, if we are talking symptomatic retinal tears, seems to be common practice is that in RD patients or the retinal tear patients, we find a U-shaped tear should be treated firstly. And the best procedure to treat the U-shaped tears is photocoagulation. Dialysis are treated with scleral buckling if there is an associated retinal detachment. Prognosis is one of the important factors. Prognosis is pattern, and at least one half of the untreated symptomatic retinal breaks with persistent vitreoretinal traction will cause a clinical retinal detachment. For example, the eyes get failed prophylactic therapy, so RD can be repaired by pneumatic retinopexy. Scleral buckling procedure or vitrectomy is usually successful in the anatomic attachment of the retina. So it's all about the very interesting information about the RD and the types of RD, as I have described all the pathophysiology, its clinical features and how to manage and the prognosis factors. So hope so you all will understand these things and be conscious about your vision, and when you are suffering from these type of problems, eye problems regarding the floaters, the flashes and the blurring of vision, so you should immediately go to your doctor and for examination, and you should